Hi everyone, good morning. On behalf of NHF, welcome to current treatments for ultra-rare bleeding disorders. You can fill out the evaluation at the end of the session via QR code. At this time, I would love to introduce Dr. Paulette Bryan.
Good morning, and thank you for being at this session on rare bleeding disorders. It's going to be a whirlwind of a tour. My goal is for you to have all the information that I have in less than 50 minutes. So sit tight, we're going to have a good time. My disclosures is that I came to the meeting. I don't have much to disclose. So let's start from the beginning. How do you get a blood clot? And you need platelets, fibrinogen, and red blood cells. And what happens is you cut your vessel, your red cells and platelets go out. The platelets are these sticky things that help form a clot. And then you get this mesh network called fibrinogen. And the whole goal is to make this mesh network so we can plug that hole. So how do you make that mesh network? You need proteins, and those proteins are labeled as Roman numerals. And the rare bleeding disorders are those proteins that are not the ultra rare, 8 and 9. So 8 and 9 is what we know about a lot. We have hemophilia A and B. The rest of those clotting factors with numbers, those are the ones that are rare. The other way I like to think about it, I tell my patients, are you making a brick wall to keep the blood in the vessel and everything out? The bricks are made of platelets and red cells, and the mortar are from that protein to give you that mesh network. Platelets are also really important, and I have a lot of patients say, well, you talked about the protein, but you didn't talk about us. Well, I hear you. I'm on your page too. And platelets, though, they look like little specks under the microscope. You might even think, oh, they're dirt. But they have so much value, and they do a lot. They really are heavy lifters in your clotting. And so you can miss some of the bags of proteins that you have that can cause you to have platelet problems, dense granular storage pool. Your platelet problems can be part of a regular disease. Hermansky-Pudlak-Chedick-Higashi is immune disease. You can also have missing the cytoskeleton, so you have these huge platelets. You can miss enzymes, and then the surface membranes are what you hear a lot about. The Bernard-Soulier, that's the receptors that help bind to the von Willebrand's, and then the Glanzmann's thrombocythemia, which, if you were in the previous section, the platelets just don't function well because they're missing that receptor. However, you have a normal number of platelets. And finally, there's bleeding of unknown cause. So what does that mean? Bleeding of unknown cause is this medical term, which essentially means we don't know. Oh, and that means we've done all the testing, we've done everything to kind of figure out what you have. We can't figure it out, but you're still bleeding. And you really need to understand that, because if you go to the doctor and they say, well, we couldn't find anything out, you may walk away saying, well, maybe I'm not supposed to be bleeding, or they don't believe me, or it's not real. It's real, we just don't have the tests to figure it out. And I just want to validate that today. So for factors for clotting, you have those clotting proteins and fibrinogen that makes a big clot. And then on the other side, you have fibrinolysis that breaks down the clot. Have you ever wondered when, well, y'all probably don't do this, but when you pick your acne, your zits, you get these scabs, but they don't become huge scabs, they just get better. Well, there's a plan for that, so that the clot doesn't continue to grow, it shuts off, and then it gets smaller and smaller, and that's the fibrinolysis portion of it. So again, there are diseases that can cause you to bleed. If you have something that holds back your fibrinolysis and then that's deficient, you can bleed from that. We are not going to talk about fibrinolytic disorders today. That's a very, very, very rare disorder. There's a couple of them I put out there. And some of the treatments we're going to talk about today, they will help you in those disorders also. And then rare vascular disorders. You can have a disorder called Ehlers-Danlos. It can make you your joints very loose. You can have abnormal scars. It's rare, but you can also have bleeding and bruising. It has nothing to do with your clotting factor and nothing to do with your platelets. Patients who have that are often very frustrated because they're bruising, but we can't figure out why. There's another disorder that's now coming into the hematology fold, the hereditary hemorrhagic telangiectasias. You get these little clusters of blood vessels where you can bleed. And then something as simple as scurvy. You know, you heard it in school in the 1800s. The sailors didn't eat their vitamin C and their oranges, and then they got bleeding from the gums. So you can have other things happening to you to give you a mild bleeding disorder. All that bleeds is not a clotting factor or platelets. These are all rare. However, we're not going to talk about those today, but if you're out there in the audience, I hear you, I see you, I just gave you a shout out. So how rare is an ultra rare bleeding disorder? Well, in the US, a rare disorder is defined as anything under 200,000 people. Hemophilia A and B and ultra rare diseases make up those coagulation rare disorder thing. But ultra rare of the coagulation disorders, they only make up 3 to 4%. Let's put it in real numbers. So if you have factor 7, you're 38% of that ultra rare, 27% are factor 11. You're 2 in a million or you're 1 in a million. So you can actually tell your wife or husband that you are 1 in a million. And you deserve that treat, whatever you like. The World Federation Hemophilia Annual Global Survey in 2020 went over hemophilia A and B and types unknown, and there were 393,000 people who reported in that year with a bleeding disorder. Von Willebrand's disease was slightly less common, less than half. And then you guys are way down here with this other rare bleeding disorder. Only 64,000 reported worldwide. Now, part of it is of the countries who reported, only 120 over 147 reported it. But the other problem is that they didn't get 100% response rate. I wanted to bring something out on this table from the World Federation of Hemophilia. If you look at 1999, everything was a bleeding disorder type unknown. Nobody knew what you had. And then you come up into 2005, 2006, you start having platelet disorders. Platelet disorder that are reported. And now a good number are platelet disorders. Also a good number are 7 and 11. So my point is that even though you're ultra rare, we are seeing you and hearing you. These numbers aren't going up probably because they're just more and more people. It's probably because we're smarter and we are recognizing that. So those of you who have bleeding disorders of unknown cause, just remember it's not your issue, it's our medical issue. We can't figure out what it is yet. All right. And you may be on that map very soon for us to validate that. So the genetics, how do you get a rare bleeding disorder? Well, it's usually an autosomal recessive trait. That means both males and females can get it. You have to have 2 abnormal copies of the affected gene. And the carrier can receive only 1 copy. And because it's a recessive gene, you know, in your mind, you think, well, they don't bleed. And most of the time that's true, but occasionally that's not the case. You do have carriers who are bleeders. And so the difference is if you have an autosomal dominant, it's one parent and there's a 50% chance that they could give to a child. But autosomal recessive, check this out. Your mom and dad are carrying the gene. They're likely don't even know they have it. Out of every time they get pregnant, there's a 25% chance that they'll have a child who's affected, a 50% chance that the child will be a carrier, and another 25% chance that the child is normal. So imagine you're a woman, you have heavy periods, nobody in your family bleeds, particularly your parents, and you go into a center that not typically treats coagulation disorders. I mean, you probably will get the cold shoulder and you'll be all right, ain't nothing wrong with you kind of thing. But that's not true. Here's the science, and you have to remember that if you have a rare bleeding disorder, not everybody is aware. So let's look at the symptoms. The symptoms can be like a nosebleed all the way to bleeding in your brain, which is very serious. And that's kind of unexplained. If you have hemophilia, it's usually joint bleeds. But now we're discovering sometimes hemophilia patients have nosebleeds. We just haven't been paying attention. But mostly in rare bleeding disorders, it's nosebleeds, heavy periods, but there can be joint bleeds or bleeding in the brain. The other thing is that the factor doesn't correlate with the severity of your disease. If you know someone with factor 8 or 9, the factor 8 is less than 1% or less than 9%, and it's severe. In factor 11, your factor could be 35, 40%, and you could bleed terribly. And so there's usually not a correlation, except if you have fibrinogen or factor 13. Other than that, it's a guess. So the other thing for a rare bleeding disorder, the physician has to treat the patient, not a number. We have to look at you. And females can experience heavy menstrual bleeding, anemia, miscarriages, or pregnancy-related bleeding. So I put all of those Roman numerals out here, not to overwhelm you, but just to see, we're going to go through a lot of these today and what the treatment is. But I wanted to highlight that the symptoms are very similar. HMB is shorthand for heavy menstrual bleeding. And notice almost everybody has heavy menstrual bleeding. So that's if you're a lady or have a uterus. So that's an important thing to know. Also, fibrinogen, you can have first trimester miscarriages. That doesn't go along with a bleeding disorder, but that can be your first presentation. You can't get pregnant. Also, factor 13, it may be an issue for you. You can also get bleeding in your joints. You can see factor 2 and factor 7. The next point I wanted to bring out is that the symptom-free level varies between each different type of factor. So it depends on what factor you have, what is normal for you. And then the severity, usually it's non-detective, but you can bleed badly with a factor 7 level less than 10%. And then factor 11, we don't know. You could have a level of 30% and bleed significantly. So who should seek help if they have a rare bleeding disorder? If you're told you have low iron, if you're bruising or bleeding, or someone in your family is a free bleeder, including von Willebrand's or hemophilia. If you have bleeding from dental surgery or childbirth or any other kind of surgery, if you have frequent nosebleeds, if your cuts bleed longer than normal, or if you have those big bruises that are dark blue or larger than a quarter. When should you seek help if you have heavy menstrual bleeding? If your periods are coming more frequently than 21 days, if it comes once every 90 days, that's not normal unless you're on hormone therapy. If it lasts longer than 7 days, I mean, very heavy, that needs to be brought into attention. If you experience flooding or gushing when you stand up, or you can't go to work or school because of your period, if you're soaking your pad every 1 to 2 hours or more, or if you pass those big blood clots, you should be evaluated, all right? You don't have to have all of that. Some of that needs to come, you need to come to see the medical team. So I'm gonna stop there for 2 minutes, take a deep breath,
And we talked about ultra rare bleeding disorders, how you get it, the symptoms. If you suspect you have a bleeding disorder, what symptoms may prompt you to seek help. And then if I'll take questions, and if not, we'll move right into why you came. You want to know about therapies, how to treat these things. Are we here together? Okay. Okay. Yes, our mild type A treatments discussed here. I didn't have a particular factor 8 in my slide, but what we use for hemophilia type A, I did review that on DDAVP. We're going to get there. We're going to get there on Amicar and factor replacements. So not specifically, but in general. All right. Anything else? All right, put on your seatbelts. We're going to try to go through a lot of these factors in a short period of time. So first of all, I want you to give your medical team grace. Give them the benefit of the doubt and maybe even hug, because making the diagnosis of these things is very difficult because it's rare. Imagine 1 in a million or 2 in a million, and they all have similar symptoms. So making the diagnosis is difficult. Treatment is often based on replacing the missing factor. But as opposed to what you saw in the last session, a lot of these, we don't have the specific factor. We have workarounds, but it's not perfect. The other thing is the plasma level we get may not be predictable. We may not get 50 or 60%, or if we do, you may still be bleeding. And then there's risk of clotting or thrombosis that can occur with some of these treatments. So first of all, it's difficult to make the diagnosis. In von Willebrand's, it can take women 16 years to get an accurate diagnosis. So with an ultra rare, it's probably going to be a little bit longer, but being prepared and knowing what your symptoms are and discussing and going to experts is going to be helpful. So we're going to talk about today how to treat each deficiency. We're going to have on-demand, preventive, and then GYN, how we would approach treating. I don't want you to get exactly how we do everything, but I want you to get why it's important to go to your hematologist before you have a baby or have heavy periods or surgery. We're also going to talk about one platelet abnormality, and we're going to discuss practical tips to help people with ultra-rare bleeding disorders to navigate the medical system. I want you to be prepared. So the first is our DDAVP desmopressin. We use that a lot, even for mild hemophilia. It's an antidiuretic hormone. It's a medicine. We give it IV, we give it in the skin or intranasally. Stimate was produced by CSL Behring, but it's on recall. Stack Pharmacy is producing this now for the nasal form. It's used in most platelet syndromes, mildly low factor 8 and von Willebrand's. It improves the stickiness of your platelets, and it causes a release of stored factor 8 and von Willebrand's. We avoid using it in children less than 2 years of age. What it does is it causes the water or fluids to be retained. Your salts can go down in your blood, and we've seen children with seizures, also elderly people. You also want to use it with extreme care if you have congestive heart failure or some other cardiac disease. And in pregnancy, you've got fluid shifts anyway. So DDAVP might not work for you, but it's something that it may work. We have to talk to your physician. The next step that we use is antifibrinolytics. As I said before, you have coagulation, and then you have fibrinolysis, which breaks down that clot. It's like the yin and the yang. You have something punching and something receptive. The fibrinolysis, it breaks down the clot by plasmin. The antifibrinolytic holds that plasmin from breaking down the clot. It's like putting a choker chain on a very vicious dog. And this is a non-hormonal medicine. We use it a lot over numerous rare bleeding disorders. The two types we use, Amicar and transexamic acid. You might know that transexamic acid is Listita if you've had heavy periods. It comes in oral, mouthwash, and IV, but the Amicar comes in liquid. So I use it a lot in children versus adults. Not recommended for urinary tract bleeding. And the reason is it can cause a clot in your urinary tract. That's a small area, and it's not recommended if you're in renal failure. It works the best in places where there's a lot of fibrinolysis, your nose, your mouth, and your urogenital system. And it can be used for minor surgeries and an adjunct to major surgeries. And it's used to prevent postpartum bleeding and prevent rebleeding. They're not recommended near a product called a prothrombin complex product. Plasma is the next part in our armamentarium. We used to use that a lot before we had recombinants and product specific. However, it's still used a lot if you have a rare bleeding disorder. If you don't know what plasma is, we take your blood, we spin it down. The red cells are at the bottom, the white cells are in the middle, and then up here is the liquid part of the blood. So that's all plasma is. And we treat it with solvents to prevent viral transmission. Advantages, most hospitals have it, it's low cost. The disadvantage is it takes a lot of plasma to correct a bleeding disorder. So you might get too much volume if that's all we have. The other thing is it's frozen, fresh frozen plasma. And so again, that's helpful because it's readily available. Cryoprecipitate is the dregs or the bottom of that plasma once you dethaw it. That is super concentrated with von Willebrand's disease and von Willebrand's factor and factor 13, fibrinogen, factor 8. It has low volume, so you can give that in a volume issue, and it works well. It has to be frozen in a timely manner to be effective. So plasma-derived factors, we went from plasma, which has all the factors, now we're going to go to the plasma-derived factors. They're made for a specific deficiency for pooled plasma. Fibrinogen, we have rheostat, factor 10, coagdex, and factor 13, corifact. Prothrombin complex is just plasma factors from that have numerous factors, 2, 7, 9, 10. We hate to give you a bunch of factors you don't need, but sometimes that's the only place we can get that particular factor. Again, it's treated to reduce viral transmission, and we used to use this a lot for patients with factor 10. Recombinant factors. Well, you probably know if you have factor 8 and factor 9, there are recombinant products for you. But for if you have a rare bleeding disorder, it's only factor 7 and 13. And the recombinant products are made in a laboratory. We don't take them from another human. And they're usually made in animal cells, such as a baby hamster kidney cell or a rabbit cell. If you're allergic to those proteins, you shouldn't get these products. But most people have received them with very little issue. The major advantage is it's recombinant. You don't have a lot of volume for it. There's pretty much you're eliminating the exposure to a pathogen. The disadvantage is it costs a lot. And so your insurance may or may not approve it. You have to sometimes we have to fight with the insurance companies for a particular use for it. The other thing, there is a black box on it that factor 7 can cause arterial and venous thrombosis in the wrong circumstances. So again, it's not totally get out of jail free card because there are some complications from it, but we do have commercial products that are recombinant. Once we move from replacement, there are other supportive therapies we can do. There's hormone therapy using estrogen and progesterone, particularly for women with heavy menstrual cycles. You can use an IUD, progesterone mini pill, and transdermal patches. Local control things we can do, there's a product called thrombin. That's the product that helps make that mesh to keep the blood in the vessels and stop oozing. It's very expensive, but that works. And there's a new product that I have not used called Celox. And they have used that in emergency rooms for people with arterial bleeds, and that helps also with bleeding. Surgical treatment. There's a variety of surgical things that you can use for local control. They can make collagen that helps. They can make these fake clots that don't stick. They can make fibrin or fibrin sealants. I bring that up because if you're having surgery, it is really important that you talk to your hematologist before the surgery, because a lot of ORs don't have these products on the shelf. You need to ask for them. CryoCuff is something that I still think is very effective. I have a little picture here where you can put ice and cold water, and it can go around your knee or your elbow and use some compression with ice. And ice often works great for inflammation. Lastly, silver nitrate. Sometimes if you have a nosebleed, they'll use that to burn the vessels. It's caustic. It hurts. It hurts healthy tissue. So we don't use that a lot. If you have nosebleeds, there are many things, even over the counter, like Afrin, things to keep your nose nice and moisturized, saline spray. I like the AYR nasal gel. Things like blood stop nasal seats, which is a polymer of seaweed that causes a clot, but it doesn't stick. So when you pull it off, you don't rip it off and it bleeds again. Wound seal powders and quick clot. I have to caution, some of these I've used in the nose, and some of my patients say it burns. It burns a lot, but nasal seems to be a good one if you have burning. And the reason I put this up, there's so many products to try. If something doesn't work, you can try something else. And lastly is nose buds. When I start practicing hematology, I'd say, oh, just get a bag of frozen peas. That'll work. Put that on your nose. Now we have these cute little nose buds that you put in the ice box, and you can pinch your nose, and you can reuse that. All right? Platelet disorders are very similar to what I just reviewed, but there is a therapeutic decision you have to understand. When we treat platelet disorders, it's not on a particular lab test often. Sometimes it's platelet aggregation studies or flow studies, or you have low platelet numbers. But sometimes everything is normal, your platelets aren't working, and we're treating you. And that's because we don't have a lot of tests to try to figure out what you have. And they're very expensive. So if your insurance company doesn't pay for all of those tests, it can be very, very frustrating. So it's based on you bleeding, and we think you have platelet disorder. The second thing is aspirin and Motrin can make your platelets not work for up to 2 weeks. So please, even if your doctor or your lab tech doesn't ask you if you had platelets, if you had aspirin in the last 2 weeks or Motrin, please let them know. The other thing is that aspirin sometimes is in cold remedies. So be aware of that because that'll affect our testing. There's not many therapeutic options for platelets. Estrogens we've used a lot. Estrogen dial seems to help with the platelet stickiness. We can use oral estrogen, transdermal estrogen I've used for folks who had GI bleeding, and estrogen creams if you have nasal bleeding. Be aware, I've had a few young girls, I put it on, and they've had breast development because they absorb the estrogens. That is not, that's just part of what it does. We usually, if they've had severe bleeding, just press on, but those are things just to be aware of. Platelet disorders, we use the DDAVP, the Stimate. That's often good in storage pool disease, or if you're having a mild dental procedure. Platelet transfusions, if your platelets don't work well and we don't have anything that can support you through, that works well also. The problem is you might develop antibodies to the platelets that we give you. So it's not the first choice. The first choice is something supportive. But if we have to, that's what we do. And then antifibrinolytics, particularly the tranexamic acid, is really good for dental extractions. And factor 7, some patients have had treatment success with factor 7. If you were in the talk this morning with Dr. Sidonio, sometimes we give it prophylactically 2 or 3 times a week. Sometimes I've had to do it every day. Sometimes it works, sometimes it doesn't. So the last thing about treatment is timing. When you treat, some people treat on demand. And then prophylaxis. Prophylaxis means we're trying to prevent you from bleeding. First of all, is it needed? Not everybody who has a rare bleeding disorder needs to be treated preventively. Sometimes they may only bleed for surgery or if they have trauma. And then for how long? For instance, if I have a little kid who had a bleed in his head and he's just learning how to walk, I probably will put him on prophylaxis if I can, because he's going to fall and hit his head again. So, but once he's mastered walking, I'll probably lower my expectations of how much I should do for his bleeding. Treatment of heavy menstrual bleeding is a main deal. Sometimes you just treat around the period, and then the rest of the time you're fine. You want to treat pregnancy, labor, and delivery. And a lot of these things have special warnings and special guidelines. So I put my chart up to here, say, this is the part we're really going to speed through, and I'll do certain specifics of what we need. So fibrinogen deficiency is our first deficiency for our rare bleeding disorders. And the good news is there's a plasma concentrate. It is from a human, and it's pooled, and it works well. If you don't have that in your particular hospital, you can use cryoprecipitate or FFP. We also use the antifibrinolytics. Remember putting the dog chain on the fibrinolysis. There's long-term prophylaxis is not usually required, except if you have no fibrinogen and you've had an intracranial hemorrhage. We don't want you to bleed again. In that instance, we might put you on preventive therapy. And then lastly, some of these fibrinogen patients can have thrombotic risk. I mean, it doesn't make sense, but the yin and the yang, it's all kind of connected. And so majority with congenital disorders don't have thrombosis, but if you do, it can be in your arterial or your vein. We don't know why. For gynecologic, for fibrinogen deficiency, if you have menorrhagia, oral hormone replacement, and antifibrinolytics. Almost every slide, I'll probably use that. But if you have afibrinogenemia, then you have a high risk of miscarriage. And those people who don't get fibrinogen during their pregnancy usually miscarry by 6 to 8 weeks gestation. And dosing, excuse me, thank you. Dosing may increase also during your pregnancy. So you may get through, but as you go through your pregnancy, you clear fibrinogen a little bit faster. And then around labor and delivery, you have to have fibrinogen for 3 days after. So what am I saying? You have a very rare bleeding disorder. You can manage and become pregnant and have the family you want, but you need your GYN specialist and your hematologist to work well before you get pregnant. Otherwise, you may have complications. Prothrombin deficiency, there's no single factor concentrate available. So you may say, wow, but you can use the prothrombin complex concentrates, the FFP, and then antifibrinolytics are used for minor bleeding. It's very rare that we use it in pediatric cases for long-term prophylaxis. And again, if you have GYN bleeding, you want to use antifibrinolytics, you want hormone therapy for severe deficiencies. We don't have any data on IUDs, but when bleeding is severe, the prothrombin complexes are very helpful. And when you get close to labor and delivery and postpartum, if your factor 2 is below 20%, we want to treat you for 3 days. Factor 5, again, no single commercial factor 5 concentrate available. I mean, wonk for my team. I wish I could have given a talk before. we don't have a lot, but the virally inactivated FFP is preferred. Factor 5 is in platelets, so you may get a platelet transfusion. It's not common to have long-term prophylaxis. There's a weak correlation with your factor level and what we give you. And gynecological and obstetrics, it's the same bat station. Hormone therapy, antifibrinolytics, and when you get close to delivery, you need to have FFP or platelet transfusions to prevent prolonged bleeding. And bleeding can occur like during delivery or after you go home, and that's why it's important that we cover this. Factor 7 deficiency is bleeding is unlikely with that if it's over 10%. There's several options worldwide to prevent bleeding with FFP and all these other things, but here in America we use recombinant 7A. We use a lower dose than what you normally would use. We usually don't use prophylaxis, but as you heard this morning, and I've had patients that we've had, and factor 7, less than 2% is more likely to experience a severe bleed. 46% of patients with factor 7 have heavy periods. And so you can use factor 7 first day and second day. It's IV infusion. Postpartum hemorrhages are rare. And you have to check the level in your third trimester. So if you have a low level, we want to treat you prophylactically and then 3 days later. So if you get pregnant, you may whiz through your first and second trimester. Your third one, we really need to treat you. Factor 10, I'm turning the corner, guys. There's a treatment for a highly purified factor 10 concentrate. It was first approved in 2015. It's indicated for demand prophylaxis, and long-term prophylaxis is only recommended if you have heavy periods or severe bleeding. And the treatment for gynecologic is the same, tranexamic acid or hormonal therapy, but we do give factor 10. Severe factor 10 females can experience miscarriages, abruptions, premature delivery. Factor 10 increases during pregnancy, so we want to check it in first and third trimester. We want to treat based on bleeding. And again, I gave you some dosing. Factor 11, this is the most difficult one to treat because you can bleed with a factor 11 level 19%. And there's no commercial factor available in the United States. It is in Europe, but not here. So all we have is FFP, DDAVP, and some people have used recombinant factor 7A. Usually you don't need routine prophylaxis. Most of the patients I've diagnosed, they were fine. They went to surgery. They had an appendectomy, and all of a sudden they were bleeding. And there's variable bleeding correlated with it. Spontaneous bleeding, other than menorrhagia, is uncommon. And you want to do the same thing for your GYN bleeding. You want hormonal therapy, tranexamic acid. You want to treat on demand. Consider FFP and tranexamic acid if you're going into labor and you have very low levels of factor 11. And then low factor 11 increases the risk of postpartum hemorrhages. So 20% of the women with severe factor 11 have excessive bleeding. The last thing is neonates have half the level of adults for factor 11. So a lot of times it's difficult to make the diagnosis. If it's a little bit low, it's probably going to be normal when they get 6 months to 8 months. However, it's very low, and it's possible that you can have a child with factor 11 deficiency. All right, factor 13. This is the last of our factors. It's made up of two alpha chains and 2 beta chains. The individuals lacking the alpha chains tend to have the most severe bleeding phenotype. Those lacking the beta chains, not so much. There is a plasma and a recombinant commercial product available, and the factor 13 that's plasma derived, treats both the alpha unit decrease in the beta. The factor 13 recombinant wise only treats the A subunit deficiency. So I put them both out there. The Corfac is from Behring, that's plasma, and the Trenton is the recombinant. It's every 4 to 6 weeks you would use it, and you can also use cryoprecipitate or FFP. These are IV medications. The long-term prophylaxis is really important if you've had life-threatening bleeding or intracranial hemorrhage. The factor 13 long half-life permits you to do maybe once every 4 to 6 weeks or monthly. The gynecologic portion of this, though, you're more likely to have miscarriages. And so if you have factor 13, you need to get that through your pregnancy. And you have to begin by week 5 of gestation, or you're likely to have issues. We also have to follow your troughs and your peaks. And if you have a cesarean section or labor and delivery, we need to increase that. Glanzmann is my last example. It is a platelet disorder, and you treat it with antifibrinolytics, recombinant factor 7A, or platelets. We use 90 mics per kilo every 2 hours for preoperative use. Platelet transfusions work well, except you can develop antibodies to the platelets, so it's not our first choice. If you get platelets, they have to be depleted of white cells to try to decrease this risk of antibodies. And there's some reports in the literature that you can have a stem cell transplant, and that will correct. Not a lot, but there has been some cures reported that way. And then long-term prophylaxis is spontaneous bleeding is uncommon. However, in isolated cases, we have used recombinant Novo-7, and there's a study ongoing for use in people who have repeated bleeding. For GYN bleeding, same bat station, antifibrinolytics and hormone suppressive therapy. If you're unresponsive to that, you get your platelets, and you can be treated around surgery. And again, you want to make sure you have the best preparation of platelets so you don't develop antibodies. So I said all that to say, what do you need to remember? You have a rare bleeding disorder. Yeah, I get it. There's no commercial factor for me. What am I going to do? Well, you want to consult your hematologist or HTC for any procedure, or even before menstruation starts, so you can have a plan, and for management of pregnancy, labor, and delivery. And you want to do this well before all of these things happen. We can treat you when it's happened, but it's good to do before. Everybody's symptoms and levels are different, and it's complicated. So your plan will be specific for you. Treatment plans differ because of the availability and the severity of the disease. And the more you know about your disease and the specific treatment, the better you can advocate for yourself. So what can you physically do? You can become connected with your HTC and your national experts. You can know your bleeding disorder and the emergency numbers to call. If you have a doctor, you need to have that in your wallet, because not every doctor, if you're 1 in a million or 2 in a million, they're not going to see your disease. You can wear your medical alert bracelet or necklace. And then if you have a phone, well, most people have a phone. You can put the contact ICE in case of emergency, and then put the name of the person you want, put ICE, ICE in that last name portion, and then the phone number, and you can put that in the notes. If you have an Apple phone, they have a medical ID, put your stuff in there so that people can know what you have and what product you use. I also give the old-fashioned way travel letters. Fold it up, put it in your wallet. You never know when you'll need it or you'll be traveling. And that usually has what you have, who to call, and how to manage you. Carry your medicines with you and know your product of choice. And then be aware that if you go somewhere, I had a young guy, he went skiing in Vail, and they didn't have his product, but they had a lot of good supportive services. Know that there are alternatives. That's why I put up those long lists of things for you. If you have severe disease, you really need to know how to self-infuse. All right. And I really recommend that, because if you have a mild disease, you don't know how to self-infuse, you're on vacation or you're at college or someplace else and you have a major bleed, you can treat yourself even before going to the emergency room, and that gives you a sense of confidence. So if you need to learn that, tell your hematologist of all your procedures, surgeries, including dental procedures if you're going out of town, and know your options for emergency care. And one little thing, don't call Friday at 5. If you see it coming, give us like a week or two so we can talk to your dentist, make sure your surgeon has all these products there for you. I'm telling you, preparation is in the details, how well you'll do. If you're a lady in the audience, get counseling before you start your period and starting a family, and know your risks during pregnancy and delivery, and what to expect. You probably will be referred to a high-risk fetal maternal medicine. If you're not given that option, ask for it. Because what you want is everything coordinated in the room, so nobody's like, I didn't know kind of thing. You want a good plan. You want to understand your genetics. Most of these are autosomal recessive. Occasionally there's an autosomal dominant, so you want to know that. Notify your hematologist. Also know you'll be checked for iron deficiency. And people kind of poo-poo that, but it causes mood disorders. You can't concentrate. It's a big deal. And so to prevent that, that's what we do. And you want to consider cord blood testing, and you want to discuss with your hematologist and your OB. You may say, what's cord blood? What if your child has a bleeding disorder and sticking him for blood is difficult, and he ends up with all these hematomas, or worse, he bleeds, or you can't get the blood? That's not good. So if you can get the blood from the cord blood ahead of time, you save your child undue risk, and you'll know the answer a lot quicker. So I always say, bring that up. And then wisdom teeth is a big one. We always like everyone to get their wisdom teeth before taken care of before they go to college. But, talk to your hematologist. And I say that because your adult child will be in college away from you, and wisdom teeth can bleed, and you don't want to get that phone call. So that's why we try to get those things done before they leave the nest. So other things, avoid medicines and herbs that can cause bleeding risk. Ginkgo biloba, ginseng, turmeric, Zoloft. I've had several patients go to college and have anxiety disorders, and they're on Zoloft, and they start taking them, and all of a sudden they're covered with bruises. So be aware that some of these other medicines can cause your platelets not to work as well. I tell them if they need it, they need to continue on that. I do not stop it, but I let them be aware that their platelets aren't working as well, and we just keep an eye on it, okay, and avoid aspirin and NSAIDs. Avoid high-impact contact sports if you have a rare bleeding disorder where you bleed a lot, because we don't have a lot to stop you from bleeding. That's the only reason. We want you to live your best life, but we don't want you to hurt. Consider immunizations, and then, when possible, consider participating in registries, Athens Dataset, Community Voices in Research, Rare Bleeding Disorders Database. Whatever you have, the best thing you could do is participate. One thing, you learn from that participation, but second thing, you're helping everybody in your same circumstance who's 1 in a million. And that's what we want. And you want to keep yourself informed by attending meetings like the BDC. So I'm glad you're here. How do you measure success? How do we make this? I just say living your best life. You don't have pain, you have good mobility, minimal bleedings, you don't have problems with surgery or dental support. If you're female, you don't have heavy periods, iron deficiency. You have fulfilling relationships. You can go wherever you want to go. I have one patient who went to Galapagos, which is way out there. And I was like, but he had his stimate, he had his Amicar, He could text me. He did well. In fact, he helped some other kid who was bleeding. So all of these things are planning so you can live your best life. And you have to have confidence and quality in your life. That's why we're here. So I stole these from the NHF website because they're such good pamphlets. If you have one of these are good educational materials, and there's more coming. Educate yourself all the time. And sometimes you might even want to take the pamphlet with you if you're going out of town, because you can give that to your doctor and they're like, oh, I need to call. Oh, yeah, and you can get them at the NHF booth. And then I did a few websites from where I took most of my material outside of my normal stuff that I told you about. I know it was a quick whirlwind, but I wanted to go through a lot of what ultra rares deal with, and thank you for your attention.
This is your question. So I thought you meant you want to read it first, and then you can read it however you want to read it.
Okay.
Hold it.
Okay. Well, we have one online question. Physicians seem to be scared of giving 7A Novo 7. I have mild factor 7 and have been denied the ability to carry any factor products. My treatment plan has been giving Kcentra instead of Novo 7. Should I get product? Is the risk actually lower with Kcentra in a mild 50% factor 7 patient than Novo 7, or is this just my provider being uncomfortable with the risk of thrombosis related to giving 7A? And I can't speak to your particular thing because Novo 7, there have been some attributes to clotting. It's usually you've gotten a lot of the drug, or you're infected, or other things. Kcentra is cheaper than Novo 7. And it might be that if your doctor's having trouble getting approval from your insurance company, that's why they're taking that second look. The other question is, how often have you used Kcentra? Like if you're carrying it, but you never actually needed it, that might be a good choice too. And so usually for factor 7, we do recommend recombinant Novo 7. And so what I might do is borrow the book or download the book from NHF and give it to your doctor. Oh, yes.
Test. Sorry, do you?
Any special considerations with aging with Glanzmann's, like brain hemorrhage, spinal infarct, anything that we need to consider as we're getting older?
That's a great question. And the answer is we don't know. I've had 2 Glanzmann's patients that had really heavy periods. One I saw 6 or 7 years after she left me, and she was like, "Oh, I'm doing great. You know, I don't need Novo 7. It's better." And then I have another little girl. It seems like the older she's gotten, the more issues she has gotten. I can't tell you that the intracranial hemorrhage is usually for neonates and in that newborn period. But I don't think we know because we haven't done those longevity studies like my mom is 88. We couldn't tell you. I think your question is a good reason why we should start cooperating and putting information in those registries, particularly the community research and the rare bleeding disorder one, because we don't know. We really don't know. For instance, like if you were older, and you had a heart attack, or if you had a stroke, what would that look like? And we don't know.
Hi. Can you share any information that you have on the HMB001 study that's going on?
I don't have a lot on that, just what I just learned, but I'm sure, I think Dr. Sidonio may have the if you see him, just grab him.
I saw that you mentioned for platelet disorders on your platelet disorder slide, not your Glanzmann slide, that you use factor 7 for that. What is your criteria that makes you use factor 7? And then a follow-up question would be, how do you get insurance to approve it?
So factor 7 is indicated for Glanzmann. Yes. Right. And so how I do it is we use all those supportive things first, including sometimes even platelet transfusions. And if you develop an antibody to the platelet transfusion, then we go for the factor. Or if you are bleeding so much, we're afraid of that, then we call. And I want to paint the insurance company as the bad guys, because if you get to the right person, usually I can get them to understand. But all those things take time. And let's say you were going to surgery, we didn't want to use platelets. You already had platelet antibodies. I needed to use Novo 7. I probably need at least 3 to 4 weeks to get the approval and have the medicines there for you so you don't get a huge bill after surgery. Okay, perfect. My son has factor 13 and we use Corfac monthly, but we're thinking of switching to Trenton because it's non-human derived. Can you weigh in on the 2 medicines? Yes. So yes. Oh yeah. Oh, thank. So the Corfac is for factor A or B, the deletions, and it's usually 4 to 6 weeks. It's plasma derived. The Trenton is only if you're missing the factor A, the A2 subunit. So if you are missing the beta 2 or the A2, then you don't want the recombinant. The recombinant is only if you're missing the A2 subunit. Does that make sense? Yeah. The second thing, which I'm taking care of my mom and I'm doing her insurance things, and it just seems to me very random. But if your insurance company won't pay it, or if it's a non-formulary, sometimes it's a lot of effort to push to get that other product. It's not that it's impossible, but it may be that was what your doctor was told to use. And so if he has a deficiency in the B2 subunit, then he's probably on the correct product. If it's the A2, then perhaps having that discussion with your doctor and find out if he's truly eligible and what are the barriers for using the other product. Yeah, and it's sometimes too, remember, well, you're too young, but in the old days, we were on plasma-derived factor. Then we went to recombinant factor. And then once we were on recombinant factor, there was more inhibitors. And then we went back to plasma-derived factor. And so it's a safe product if he's doing well and it's covered. It's just something to think about. Now, if it's not covered, and the good thing for you is you have a plan B, if ever that product wasn't covered. Yeah.
So we're at time. I'm going to go ahead. Oh, okay.
Just real quick for the question that was just asked, it is possible to get approved to switch product with no problem. I was on Riostap for years, working fine, working great. I wanted to switch to Fibriga only because of the financial support that was available. My insurance, no issue. Bada bing, bada boom, instant approval. It's working great.
Perfect.
In fact, it was funny because right after that, I had to have a biopsy and a hysterectomy, and we used Fibriga.
Okay.
And also, I had a question about, is anybody doing anything about the issue of, obviously they're not going to have our product in the emergency room, but they won't let us bring our own.
Whoa.
If you're comfortable just having a side chat in the hallway. would
Yeah.
that be okay?
Yeah, I'll have a side chat in the hallway.
Thanks.
So can we go to the evaluation slide? So these evaluations, of course, help us plan for 2023. So if you have a moment, go ahead and scan the QR code. We also get this sent out to you at the end of the day for each session you attend. And yeah, enjoy lunch. And any other questions, please find Dr. Bryant in the hallway. Thank you all so much for your time today. And let's give a round of applause for Dr. Bryant.